Thank you for the invitation. My name is David Conen. I'm a clinician scientist from the Population Health Research Institute at the McMaster University in Hamilton, Canada. I originally am from Switzerland, and that's where the current study has been conducted. So a few years ago, we noticed that patients with atrial fibrillation have an increased risk of dementia. Part of this association is certainly mediated by an increased risk of clinical strokes in patients with atrial fibrillation. This increased risk can be mitigated by giving oral anticoagulation or blood thinners to patients with atrial fibrillation. However, even in patients without clinical strokes, a significant association has been observed with dementia in patients with atrial fibrillation. This has led to our hypothesis that there may be much more going on in the brains of atrial fibrillation patients than clinical strokes. Like an iceberg that below the water surface has a large mass that is going undetected if you don't look closely. So we have launched in 2014 a large cohort study of almost 2,000 patients who underwent brain MRI imaging between 2014 and 2017. All patients also underwent cognitive testing on a yearly basis. Of the approximately 1,750 patients that were initially scanned, we successfully rescanned approximately 1,230 patients after 2 years of follow-up with another brain MRI. And that is the current study population. We conducted a prospective observational cohort study among 14 sites in Switzerland. All patients had a large clinical CRF that was completed. As I already mentioned, all patients underwent brain MRI scanning at baseline and after 2 years, and all patients had cognitive testing on a yearly basis. We found that in our study population, which included 1,227 patients with a mean age of 71 years at baseline, the patients were very well treated. 90% at baseline received oral anticoagulation, and at the 2-year visit, 84% received oral anticoagulation. So these patients were very well protected. Nevertheless, we saw that a significant number of patients had a new brain infarct at the 2-year follow-up MRI scanning. 68 patients had a brain infarct, which means 5.5% of all participants had a new brain infarct that was not present at baseline, despite optimal medical treatment with oral anticoagulation. These brain infarcts were not clinically silent, although they occurred largely in patients who did not have a clinical stroke in between the visit, meaning that 75% of these patients with a new brain infarct were taking oral anticoagulation and did not have a clinical stroke, meaning that they were so-called clinically silent. Despite this, we found a significant association between cognitive decline and clinical brain infarcts, meaning that patients who had a brain infarct in between visits, so-called silent brain infarct, had a stronger decline in cognitive function compared to those who did not have a brain infarct on the MRI. These associations were clinically small, so there were relatively small differences, but they were statistically significant. And we did not expect large differences because, as I already mentioned earlier, the average follow-up between visits was only 2 years, and it takes usually a long time for cognitive dysfunction to become clinically apparent. approximately 45 to 50% were taking conventional vitamin K antagonists, while the other half was taking the more novel oral anticoagulants. We haven't looked in detail yet whether there were differences between these two groups studied, but that will certainly be one of our first next analyses to see how was the INR in patients with warfarin or other vitamin K antagonists, and whether there was differences between the two groups, but we haven't done those analyses yet. Despite the fact that most of our patients were optimally protected according to current clinical standards with oral anticoagulation, 5.5% of participants with atrial fibrillation had new brain infarct on brain MRIs after 2 years of follow-up. These brain MRIs were mostly clinically silent, meaning they were not associated with the clinical stroke. However, they were associated with cognitive dysfunction. Longer-term follow-up will show whether those differences in cognitive function increase and whether those clinical brain infarcts were associated with development of dementia in these patients. Further studies will need to show whether there are clinical risk factors that may be treated to protect the brain from silent brain infarcts, such as high blood pressure, diabetes, or smoking. However, we also need to study whether some patients will need more than oral anticoagulation alone to ideally protect their brains. Because, importantly, there's a clear role, and oral anticoagulation is very, very effective in patients with atrial fibrillation and should be given to as many patients as possible. However, there may be a group of patients where this treatment may not be enough and more treatment need to be given.